Welcome to the deep dive, where we take complex source material and really transform it into actionable, fascinating knowledge. We're here to give you that shortcut to being truly well-informed.
It's great to be here.
So today's topic is going to pull us deep into the world of acute surgical decision-making. We're tackling a highly specialized clinical guide focused on something called a right iliac fossa mass.
I know, it sounds incredibly technical.
It does. But before your eyes glaze over that term, it just describes a palpable swelling, something a doctor can actually feel in the right lower corner of your abdomen.
That's it. It's a lump in a very specific place.
And our mission today is to transform this medical textbook content, which, let's be honest, can read like a checklist of horrors, into a surprisingly insightful look at how human diagnosis actually works.
It's a perfect example of that process.
It's really a masterclass in what they call differential diagnosis, showing how just one single symptom can be caused by anything from severe constipation to a life-threatening emergency or even a slow-growing cancer.
The range is just immense.
We're exploring the incredible variety of things that can hide in one small anatomical space, and some of the really counterintuitive, sometimes risky management protocols surgeons have developed to handle them.
Yeah, the what to do is often not what you'd expect at all.
And even if you are far outside the medical field, this deep dive highlights why context, a patient's age, their gender, travel history, their symptoms, is everything.
It's all about the context.
Because when one small, palpable area of the body can signal 8 completely different and often contradictory problems, the structure of the inquiry, that becomes the most critical tool a clinician has. Okay, let's unpack this clinical dilemma, starting with the literal geography of the human body.
That's the absolute right way to start, because the RIF mass is it's the ultimate example of anatomical complexity creating diagnostic chaos. And the stakes are huge. As you mentioned, we're talking about a physical symptom that forces a rapid decision between, say, benign observation, aggressive surgery, or very specific long-term medical therapy, and the geography of the right iliac fossa, or RIF. It's basically a high-traffic junction box for multiple, completely separate body systems. That's why a mass here is such a clinical challenge.
So let's start with that foundation then, defining the territory. What exactly is the right iliac fossa, and what makes a mass there so diagnostically complicated?
Okay, so by definition, an RF mass is simply a palpable swelling in the right lower quadrant of the abdomen. But let's unpack that word, palpable.
Yeah, what does that mean in practice?
It just means the mass is substantial enough, or maybe close enough to the surface, that a skilled clinician can feel its presence. They can feel its shape, its consistency, its location, just during a physical examination. And that simple ability to feel it, that's the very first piece of data.
Okay, so that's the what. Now for the why. Why is it so complex?
Right. So the RIF is a small zone. It's roughly where your hip bone flares out on the right side. But it is home to an extraordinary density of anatomical real estate.
I like the way you put that.
You should think of it less like a quiet cul-de-sac and more like a crowded utility closet where all the internal plumbing, the wiring, even some of the framework are all packed tightly together.
A packed utility closet. That's a great analogy. So when a mass appears, the clinician doesn't just check one system. They have to check everything in the closet.
Precisely. If they feel a mass, they are immediately confronted with the fact that it could come from several distinct and completely unrelated anatomical systems. That's the root of the challenge. We basically have 5 broad categories of origin we have to consider all at once.
Okay, so what's number 1?
First, and probably most commonly, we look at the gastrointestinal structures. This region has the critical components of the lower digestive tract. The end of the small intestine, the ileum, the beginning of the large intestine, the caecum, and of course the appendix itself.
So diseases there, like appendicitis or colon cancer, are big players.
Huge players, highly prevalent.
Okay, so that's the plumbing for nutrients and waste. What about the systems right next door?
Immediately adjacent are the genitourinary structures. A displaced or an abnormally low-lying kidney, what we call a pelvic kidney, can easily be felt down in the RAF.
A kidney can be that low.
It can. And what's more, if the kidney above is blocked, it can swell with fluid, a condition called hydronephrosis, and that swelling can actually extend down into this lower quadrant. You can easily mistake a swollen kidney for a bowel or even an ovarian issue.
Wow. Okay, so we've got the digestive system and the urinary system overlapping. What's the next big category?
Then we have to consider the musculoskeletal structures, specifically the psoas muscle. It's a large muscle that comes from the spine and runs down to the hip. It's what lets you flex your hip.
And that can cause a mass.
If that muscle gets infected, a psoas abscess, the swelling pushes forward and becomes palpable in the RAF, and it perfectly mimics an abdominal problem when the real root cause is actually muscular or even spinal.
That's incredible. So that's 3 systems. What's number 4?
Fourth is the lymphatic structures. This region has chains of lymph nodes in the mesentery. That's the tissue that kind of holds the intestines in place. And these nodes can get inflamed, which we call lymphadenitis, or they can become cancerous, like in lymphoma.
And these feel different.
Often, yeah. These masses are typically more mobile than, say, a fixed bowel tumor.
Okay. And the final category, which has a whole other layer of complexity.
Critically, in females, we have the gynecological structures. This includes the ovaries and the fallopian tubes, so things like ovarian cysts, tumors, tubo-ovarian masses, or the extremely urgent diagnosis of an ectopic pregnancy.
Where the pregnancy's in the wrong place.
Exactly, where a fertilized egg implants outside the uterus. All of these fall within the RIF catchment area, and they all demand immediate specialist attention.
So just to recap for everyone listening, we have one small area, the RIF, that contains the end of the small bowel, the start of the large bowel, the appendix, the urinary system, a huge hip muscle, lymph nodes, and, in women, the reproductive organs. 5 completely distinct origins for one single symptom you can feel.
The challenge is enormous. It absolutely requires a comprehensive, structured framework to prevent what we call diagnostic omission. If you miss just one of those 5 anatomical origins, you are highly likely to miss the required and potentially life-saving intervention.
And that's why this structured clinical thinking is so powerful.
It is.
And that's exactly what we're going to dive into next. The framework that clinicians use to turn this anatomical jumble into a focused list of possibilities.
Let's do it.
So here's where the clinical checklist really takes over. The sources give us a classic medical mnemonic to organize this incredibly complicated multi-system list of causes, APPENDIX. Let's break down these categories one by one, because this whole mnemonic is basically a map to all the possible diseases.
It is, and it's designed not just for memorization, but to capture the conditions that are either the most common or the ones that are most critical to avoid missing, based on their potential for harm.
Okay, let's start with A.
A is for appendicular. This is the most common cause of an RIF mass, especially in young adults. That's a high yield point right there.
Right.
But a key distinction has to be made. We're rarely talking about simple acute appendicitis because that usually doesn't form a mass you can feel. Instead, we're looking at what happens next. Either an appendicular mass or phlegmon or an appendicular abscess.
Wait, so if someone have appendicitis, I just assume the goal is to cut it out immediately. Why are we talking about a mass that develops days later?
And that's the critical paradox that really defines the treatment in this whole region. If acute appendicitis goes untreated for, say, 3 to 5 days, instead of just bursting, the body might actually launch a containment response.
The containment response.
Yeah, it uses the omentum, that's the fatty apron of tissue covering the bowels, and the nearby loops of small intestine to wrap around the inflamed appendix. It walls off the infection, and it creates this dense, inflammatory, ill-defined lump that we call a phlegmon.
So the body is literally building a wall to prevent a catastrophe.
Exactly. It's a brilliant anatomical defense mechanism. The phlegmon is just dense, angry, inflammatory tissue. Now, if that containment fails or if the inflammation liquefies, it can progress to an appendicular abscess, which is a defined collection of pus inside that inflammatory matrix.
And knowing the difference between the phlegmon and the abscess is key.
It is absolutely vital because, as we'll get into later, it completely dictates whether you can manage it conservatively or if it needs immediate drainage.
Okay, that clarifies the most common inflammatory cause. Let's move to the first P.
The first P stands for psoas. This means a psoas abscess. Imagine the psoas muscle deep in your core, like a long cylindrical tunnel. If that tunnel gets infected, often from a spinal infection, like vertebral TB, or even from the gut next door, it can fill with pus and swell up to form this large, deep mass.
But how does a clinician know if the pain they're feeling is from the muscle or from the bowel? just by looking at the patient.
This is where the physical exam signs really shine. The key diagnostic nugget here is the positive psoas sign.
The psoas sign.
Yeah. Since the psoas muscle is the main hip flexor, if you try to stretch it out by passively extending the patient's hip, it will be agonizingly painful if that muscle is inflamed or has an abscess.
Ouch.
If the patient guards their hip and cries out when you extend it, that's a powerful clue that the mass you're feeling is related to the psoas muscle, not primarily the bowel. It immediately redirects your imaging to the back of the abdomen.
That's a beautiful example of form-following function. Okay, on to the second P.
The second P often covers parietal wall tumors or, more practically, anything arising from the pelvic or renal structures that shows up in this quadrant. Our sources really focus on the renal or urinary origin here, specifically a pelvic kidney or hydronephrosis.
A kidney that low still sounds so unusual.
It is, but it happens. A pelvic kidney is just a kidney that didn't fully ascend during fetal development. So when a clinician examines a mass, they're looking for specific characteristics. They check if the mass is palatable and reniform.
Okay, we have to unpack those terms. What does palatable mean, and why is that important?
Palatable means the mass is relatively mobile and it seems to rebound. If you push on it suddenly, it feels like it's floating a bit within the abdomen, separate from everything else, and it kind of bounces back toward your fingers.
I see.
This suggests it's a fluid-filled or a solid, discrete organ that isn't rigidly fixed to the bowel or the abdominal wall, a characteristic you often find in a fluid-filled cyst or a swollen, displaced kidney.
And reniform.
That's much simpler. It just means kidney-shaped or bean-shaped. The combination of a palatable, reniform mass immediately pivots the clinician's thinking away from the fixed, irregular masses of cancer or chronic bowel disease and squarely toward the genitourinary system.
Okay, let's move on to E, which you said carries a huge amount of urgency.
E stands for ectopic pregnancy. But really, it represents the entire spectrum of gynecological masses in females. That includes ovarian cysts, tumors, or tubo-ovarian masses. This is an immediate high-priority alarm bell.
Why the immediate alarm? What's the specific danger?
Because an ectopic pregnancy, where the embryo implants in the fallopian tube, right there in the pelvis, is a true surgical emergency. If that tube ruptures, it leads to massive internal hemorrhage, catastrophic bleeding. It's life-threatening within minutes.
Wow.
And this is why the patient's context is absolutely everything. The sources mandate that clinicians must always correlate any RIF mass in a female of reproductive age with a comprehensive menstrual and obstetric history.
So, simple questions.
Simple, but life-saving. Any history of a missed period combined with pain and a mass requires an immediate mandatory pregnancy test. If that test is positive, basically all other possibilities drop way down the priority list until the ectopic pregnancy is ruled out or managed.
The stakes just couldn't be higher for that one letter.
Yeah.
Okay, let's tackle N.
N stands for neoplasm, non-specific causes. This is a huge category, but the most important specific diagnosis under neoplasm is carcinoma caecum.
Which means cancer of the caecum, the start of the large intestine.
That's it. And this sounds like the big one the doctors are always trying to avoid missing.
Why is this one so significant here?
It is explicitly cited as the most common malignant cause of an RIF mass. And unlike that ill-defined, tender, inflammatory phlegmon we talked about, a carcinoma caecum is typically firm, irregular, fixed. It's not mobile, and often, surprisingly, it's not that tender, even when it's large.
The crucial distinction comes from the history, right?
Yeah.
The patient's story.
Absolutely. This cancer is often associated with systemic symptoms that reflect an underlying chronic disease, unexplained, involuntary weight loss, and chronic anemia.
And the anemia is from bleeding.
From the tumor bleeding slowly, silently into the bowel over months. So when a patient presents with a fixed mass, plus weight loss, plus anemia, the probability just dramatically shifts toward malignancy, and the investigation pathway has to become aggressive immediately.
And what else falls under N?
Also under N, we have the lymphatic causes. Things like mesenteric lymphadenitis, which is just inflamed abdominal lymph nodes, really common after viral infections in kids, or lymphoma, which is a lymphatic cancer. These masses are generally more mobile, and you might find more than one, which helps the clinician distinguish them from that fixed, rock-hard caecum cancer.
Okay, now we get to D and I, which sound like the chronic inflammatory section, and this often leads to a huge amount of diagnostic confusion.
Absolutely. D stands for diverticulitis, though that's usually a left-sided issue. It sometimes covers chronic inflammation like Crohn's disease. And I stands for inflammatory, and it specifically highlights a critical, often missed infection in Western contexts, Ileocecal Tuberculosis, TB.
It seems incredible that TB of the intestine is still a major consideration for an abdominal mass. I think of it as a lung disease.
It is a significant global cause,
Yeah.
and it creates a huge diagnostic headache because clinically, and even on scans, it looks almost identical to severe Crohn's disease, and most worryingly, it often mimics carcinoma caecum.
So it's a great mimicker.
It is. TB causes chronic inflammation and scarring in that ileocecal region, and that leads to a firm, fixed, irregular mass, also associated with weight loss and anemia.
So how on earth do you differentiate intestinal TB, which needs pills, from carcinoma caecum, which needs major surgery? That sounds like a terrifying decision.
That is the central high-stakes question. You have two conditions that present as a fixed mass, chronic symptoms, weight loss. The only way to definitively distinguish them is often via a colonoscopy and a biopsy.
You have to get a piece of it.
You have to. If it's TB, it needs specific anti-tubercular therapy, ATT, a medical treatment, for up to a year. Misdiagnosing cancer as TB delays life-saving surgery, and misdiagnosing TB as cancer leads to a massive, unnecessary operation. The stakes are massive.
And Crohn's disease fits in there, too.
Similarly, Crohn's disease, an autoimmune inflammatory condition, presents as a firm, irregular mass because of chronic inflammation, scarring, and thickening of the bowel wall. And it's also primarily managed medically, but the clinical picture overlaps dangerously with malignancy.
Okay, finally, X for extraluminal. What's left?
This is a catch-all for conditions arising outside the main organ systems we've discussed. The source material highlights two: a fecal mass and a hematoma.
A fecal mass is just what it sounds like.
It is. It's severe impacted constipation, a backlog of stool. It is arguably the most benign cause, but it's critical not to miss because the treatment is so simple. It's often described as being soft, doughy, and you can actually indent it with pressure.
And a hematoma.
A hematoma is just a blood clot within the tissue. It's often caused by trauma or sometimes bleeding complications in patients on blood thinners. It just requires investigation to make sure the bleeding has stopped.
That APE-NDIX mnemonic is a phenomenal checklist. Let's just synthesize the core high-stakes distinctions that really define this whole diagnostic process.
Right. The clinical mind is constantly triangulating three key probabilities. First, the most frequent, appendicular mass, the phlegmon or abscess. That's inflammation, usually in a young adult.
Okay.
Second, the most aggressive, carcinoma caecum. That's cancer, and it's especially concerning in the elderly. And third, the most immediate danger, ectopic pregnancy, hemorrhage risk, only in reproductive age females.
And the whole investigation phase is just about moving past that common inflammatory cause to definitively rule out the urgent surgical emergency and the slow, deadly cancer.
That's the whole game right there.
Okay, so once a mass is discovered, the list of possibilities is huge. How does the clinical team actually narrow this down to a single working diagnosis? We've covered the anatomical list. Now let's explore the process. History, examination, and the crucial imaging steps.
It's a very disciplined process of gathering evidence, moving from the low-cost subjective clues to the high-cost objective images. And as we've stressed, history is king. A detailed patient account often provides the strongest directional clues.
So what are the specific high-yield questions they are hunting for in that history? Can you give us some detail?
For sure. They're looking for several critical axes of information. First is the timeline and character of the pain. Was the onset sudden and sharp? That points towards an acute event like appendicitis or a ruptured cyst. Or was it chronic, dull, and fluctuating over weeks or months? Chronic pain points strongly toward Crohn's, TB, or carcinoma.
So the symptom quality and the duration completely flips the probability matrix.
Completely. Second, systemic symptoms. Does the patient have a fever or chills? That screams infection. An abscess, an appendicular phlegmon, maybe systemic TB. Has the patient experienced unexplained fatigue, paleness, or involuntary weight loss? Those immediately push the concern toward malignancy or a chronic infection like TB.
The difference is stark.
It is. If a young patient has an acute mass and a fever, appendicitis is high up. If an older patient has a mass, weight loss, and chronic fatigue, cancer jumps right to the top of the list.
Okay, what's the third axis?
Third is bowel function. Have there been altered bowel habits? New onset constipation or alternating diarrhea and constipation, especially in an older person, might suggest the bowel is getting narrower due to a carcinoma caecum. On the other hand, chronic diarrhea might strongly suggest Crohn's disease.
And you mentioned the absolute must ask.
And we cannot and must not move past the absolute necessity of the menstrual and obstetric history in every single female patient of childbearing age. Even a slight possibility of an ectopic pregnancy means you have to act immediately. Have they missed a period? Is the bleeding abnormal? Are they using contraception? These questions are mandatory screening tools to prevent a fatal outcome.
Okay, so once they have that deep narrative history, they move to the physical exam, the tactile verification. What are the key distinctions they're feeling for?
The physical exam is meticulous. After inspection, looking for scars or visible swelling, palpation is the most crucial step. They're trying to characterize the mass along 3 key axes: its consistency, its tenderness, and its mobility.
And the consistency tells them a lot.
A ton. Is it soft and doughy? That screams fecal mass, so constipation. Is it tender, kind of rubbery and ill-defined? That's highly suggestive of an appendicular phlegmon. Is it rock hard, irregular, and fixed in place? That strongly suggests a fixed malignancy like carcinoma caecum or severe fibrotic TB.
Wow. The difference between doughy and rock hard basically separates the easiest diagnosis from the hardest one.
It really does. Then there's mobility. Can the mass be moved around? Mobile masses usually suggest they're coming from the lymph nodes, lymphadenopathy, or perhaps the ovary. Fixed masses, ones that feel stuck to the abdominal wall or the spine, those are ominous signs of cancer or advanced contained infection.
And the other steps of the exam.
Percussion is used to determine if the mass is solid, which gives a dull note, or maybe contains gas, a tympanic note. And auscultation assesses bowel sounds. Silent sounds might suggest an obstruction or a paralyzed gut, which is a surgical emergency in itself.
And beyond those standard 4 steps, the specialized tests we mentioned earlier.
Yes, the focus maneuvers are highly valuable. We already highlighted the Psoas sign for a Psoas abscess. The sources also mentioned including the parectal and pervaginal PV exams were indicated.
They're not always.
Not always necessary, no, but they're critical if the mass is suspected to be deep in the pelvis or if cancer is suspected, just to check for any spread to the surrounding tissues.
Okay, so they have the history and the tactile findings.
Right.
Now they need objective evidence to commit to one diagnosis over another. What's the imaging protocol?
The investigation phase starts with the basics and moves up. We need blood tests first. A complete blood count, or CBC, to check for anemia cancer, TB, and a high white blood cell count, the TLC, for infection. And critically, they check inflammation markers, the ESR and the CRP.
Okay, for someone who hasn't heard those terms, what is the role of CRP and TLC in this diagnosis?
TLC and CRP are serial trackers of the body's inflammatory response. Think of them like the gas gauges on inflammation.
I like that.
CRP, especially, is a protein that the liver produces very rapidly when there's inflammation or infection. So if we put a patient on antibiotics and monitor the mass, we expect the TLC and CRP to start falling dramatically.
And if they don't?
If they stay high, or worse, if they rise, it's a huge red flag. It indicates that our treatment is failing, that the mass might be getting worse, maybe progressing to an abscess, or maybe the underlying issue is something conservative management just can't touch. They are absolutely essential for dynamic monitoring.
Okay, so moving to imaging, what's the starting line?
The ultrasound abdomen, USG, is the first-line investigation. It's quick, it's safe, it uses no radiation, and it is brilliant for looking at fluid-filled structures. It can easily characterize an abscess, an ovarian cyst, or a fluid-filled kidney. It gives a quick answer for those urgent gynecological or fluid collection questions.
But it's not the final word.
No. The CT abdomen with contrast is unequivocally the gold standard in adults. While ultrasound is a good scout, the CT gives the definitive, comprehensive picture.
Why is it so much better?
Well, it clearly visualizes those retroperitoneal structures like the psoas muscle, the lymph nodes, and most importantly, it can accurately stage potential malignancies and define the relationship of the mass to surrounding blood vessels and structures. That's essential for any surgical planning.
So ultrasound screens and CT confirms, especially when cancer is a concern. What are the final definitive tools?
If the CT or the history strongly suggests a gastrointestinal process, especially carcinoma caecum, Crohn's, or TBA colonoscopy with biopsy becomes essential, this is the only way to get a tissue sample to definitively confirm cancer or chronic inflammation for Crohn's, or to look for the specific granulomas of TB. It's the final piece of the puzzle that separates the 3 great mimickers.
Anything else?
We also use tumor markers selectively, like CEA, particularly if we're tracking a known or suspected carcinoma caecum. And as mandated, the pregnancy test in all females remains the single most critical safety check in this entire process.
The diagnosis is complete. Now we enter the final and most complicated phase, management. And the complexity here lies in the fact that 2 patients presenting with what feels like the same firm fixed mass in the RIF might get diametrically opposite treatments. One is told to go home and wait, the other is prepped for major surgery.
The management protocols are the true source of insight here because they reveal the deep trade-offs and the calculated risks that surgeons have to take. Treatment is entirely determined by the specific cause, the presence of systemic infection or sepsis, and how stable the patient is.
Let's start with the non-negotiables, the initial general principles, the baseline care before any definitive treatment.
Right. Upon admission, any patient with a suspicious RIF mass undergoes immediate stabilization. They're made NPO, or nil per oral, nothing by mouth, just in case they crash and need emergency surgery. They immediately start on IV fluids for hydration, analgesia for pain, and if infection or an abscess is suspected, they begin broad-spectrum antibiotics to contain any systemic spread. And the assessment of their hemodynamic stability, blood pressure, heart rate is continuous.
So this is the most counterintuitive decision in the whole deep dive. If a young patient has an appendicular mass, a phlegmon, the first response is often not to operate. Why?
This is the core paradox. It's a foundation of acute surgical knowledge, often summarized as the viva point. Never operate early on an appendicular mass. And the reason, as you alluded to, is the high risk of a catastrophic surgical complication.
So it's actually more dangerous to operate.
In that initial phase, yes. Think back to the phlegmon. It's not a clean, distinct appendix. It's a chaotic, walled-off mass of inflamed tissue, omentum, and adjacent loops of bowel all matted together. If a surgeon goes in acutely when the tissue is intensely inflamed, bloody, and friable, they can't find the correct planes of dissection.
It's a mess.
It's a total mess. It is incredibly easy to accidentally tear the adjacent small intestine or the caecum, and that results in massive fecal contamination, complex repair issues, and a significantly higher risk of abscess or even death. It is, to use your analogy, like trying to operate on a sandbag instead of a discrete, clean organ.
So the body's natural containment, the phlegmon, is actually the biggest obstacle to immediate surgery. The conservative management is designed to exploit that containment.
Exactly. The goal is to let the body's defenses work. And the mainstay of this conservative management is called the Ochsner-Sherren regimen.
Okay, describe that regimen in detail. What does this watchful waiting actually look like?
Well, it sounds simple, but it demands extreme vigilance. It involves the principles we just mentioned: NPO, IV antibiotics, IV fluids, and strict pain control. But the real dedication comes in the monitoring. The patient has to undergo daily abdominal exams, ideally by the same senior clinician, to track any change in the size, tenderness, or character of the mass.
And this is where those blood tests come back in.
This is where our inflammatory markers, TLC and CRP, become absolutely crucial. They are measured serially every day or two. The clinician is watching those numbers like a hawk. If the regimen is successful, the mass will gradually soften, the fever will go down, and the TLC and CRP will start trending down. The mass should usually resolve or cool down in about 2 to 3 weeks.
And what are the red flags? The signs that this regimen is failing and that you have to intervene?
Failure is defined by clinical deterioration despite the regimen. So increasing pain, worsening abdominal rigidity, peritonitis, a spreading mass, or critically, rising TLC and CRP levels. Rising inflammatory markers mean the infection is winning, containment is breaking down, or that phlegmon has liquefied into an abscess.
Okay, let's assume the conservative phase is successful. The patient is stable, they're discharged. What happens next? Is it over?
No. If the resolution is successful, the patient comes back for the definitive procedure, the interval appendicectomy. This is an elective, planned surgery done only after the inflammation has completely subsided, usually 6 to 8 weeks later.
Because it's safer then.
Much safer. By then, the inflammatory matrix has been absorbed, the anatomy is clean. The primary purpose is to remove the appendix to prevent it from happening again, as the risk of another bout of acute appendicitis is high.
And is there a catch?
There's a crucial caveat, especially for the elderly. If the patient is over 50 or 60, the interval appendicectomy might be deferred or even omitted until the clinician has definitively ruled out an underlying carcinoma caecum.
Why is that?
Because cancer can sometimes present as a secondary appendicitis, and the urgency of ruling out malignancy in that age group often trumps the urgency of removing a stable appendix.
So what if the inflammation progresses to an abscess, that collection of pus? The rules change immediately, right?
Instantly. If the patient deteriorates and the CT confirms an appendicular abscess, that fluid under pressure must be relieved. The rule shifts from wait and watch to drain immediately.
How do they do that?
The preferred primary management is CT-USG guided percutaneous drainage. It's a minimally invasive procedure. Using imaging guidance, a radiologist inserts a catheter directly into the abscess to drain the pus, and this is combined with IV antibiotics.
And when is the surgeon forced to actually go in and cut?
Surgical intervention is really reserved for failure scenarios. If the percutaneous drainage fails, like if the pus is too thick or the abscess is hard to reach, or if the patient presents with generalized peritonitis, a sign of widespread infection, or if they become critically unstable.
But the principle is still the same.
The principle remains. Drain pus using the least invasive route first. And even after drainage, the interval appendicectomy typically still follows 6 to 8 weeks later.
Okay, now we move to the definitive surgical approach for malignancy, which requires the complete opposite strategy from the appendicular phlegmon. A diagnosis of carcinoma caecum demands aggressive intervention.
That's right. If the diagnostic workup, the history, CT, and likely colonoscopy points to carcinoma caecum, the approach is entirely focused on curative resection and staging. But even major surgery requires careful preparation.
What's involved in that essential preoperative prep for a cancer surgery of this magnitude?
It's complex. First, we need histological confirmation via colonoscopy with biopsy, unless a patient is completely obstructed. Second, these patients often have severe anemia from chronic blood loss, so that has to be corrected with transfusions or iron, because severe anemia increases surgical risk.
And their overall health.
Third, nutritional optimization is critical, as malnourished cancer patients heal poorly. Finally, a CT scan is used for staging to make sure the cancer hasn't spread to the liver or lungs.
And what is this standard curative surgery that addresses the mass itself?
The definitive treatment is a right hemicolectomy with iliotransverse anastomosis.
Okay, break that down for us.
A hemicolectomy means removing one side of the colon. The surgeon removes the caecum, where the tumor is, the ascending colon, and the associated lymphatic drainage to ensure all the regional cancer cells are taken out.
And the second part.
An iliotransverse anastomosis just means they then surgically connect the end of the small intestine, the ileum, directly to the middle part of the large intestine, the transverse colon. This bypasses the removed section and restores continuity.
And what if it's an emergency?
If the cancer presents acutely as an obstruction, the surgery is more difficult and might require an emergency right hemicolectomy or sometimes even a temporary colostomy, a staged procedure, if the patient is just too sick for the full anastomosis right away.
Okay, let's shift to the chronic inflammatory diseases, the great mimickers that look like cancer but need pills, not scalpels. First, Ileocecal tuberculosis.
This is a remarkable area of divergence. Despite presenting as a hard, fixed mass that mimics cancer, if the diagnosis of ileocecal tuberculosis, TB, is confirmed, the mainstay of treatment is medical management.
Because it's an infection.
It's a bacterial infection, treatable by drugs. The treatment involves prolonged anti-tubercular therapy, ATT, usually a combination of drugs for 6 to 12 months, alongside essential nutritional support. Surgery is avoided if possible because it means cutting into heavily diseased fibrotic tissue.
So when is surgery unavoidable for intestinal TB?
Surgery is reserved for complications or diagnostic failure. The main reasons are established intestinal obstruction, when the scarring is so bad that stool can't pass perforation, which is a hole in the bowel, or, most commonly, persistent diagnostic uncertainty. If, even after a biopsy, the team cannot definitively rule out carcinoma, then a limited resection might be necessary to remove the diseased section and get a conclusive diagnosis.
And finally, Crohn's disease, which shares many characteristics with TB.
Crohn's disease management follows the same conservative principle as TB, though the drugs are different because it's an autoimmune inflammatory condition. The primary treatment is medical management. This includes corticosteroids to stop flares, immunosuppressants, and biologics, which target the specific proteins driving the inflammation.
And surgery is a last resort.
Only for complications. Obstruction, fistula formation, abscesses, or the complete failure of medical therapy to control the disease. And crucially, the sources emphasize a bowel-saving approach. Surgeons will only remove the absolute minimal amount of diseased bowel because Crohn's tends to affect multiple segments and can recur at the surgical site. Every inch of bowel is precious.
That distinction, the imperative to save bowel in Crohn's versus the extensive removal required for cancer, is maybe the most compelling insight into how these diagnoses completely change the surgeon's objective.
It really is.
Let's quickly confirm the management for the remaining important cases from the mnemonic, starting with the Psoas Abscess.
For Psoas Abscess, the path is pretty clear. Broad-spectrum antibiotics plus CT-guided percutaneous drainage. Because that mass is deep in the core muscle, CT guidance is vital to ensure the needle safely reaches the pus without damaging surrounding organs.
And surgery.
Surgical drainage is only pursued if the pus is too thick to drain or if the abscess is multiloculated, meaning it's partitioned into small separate pockets that a single needle can't reach.
The gynecological masses. That requires a specialist team approach.
The rule is absolute. Always rule out gynecological causes in females. The moment this suspicion is raised, a mandatory gynecology referral is made, supported by a USG pelvis and tumor markers. Management varies dramatically, from emergency surgery for a ruptured ectopic pregnancy to simply monitoring a small, uncomplicated ovarian cyst. The point is, the correct team needs to be involved immediately.
And let's end this section with the most straightforward diagnosis. The fecal mass.
The fecal mass is often a diagnosis of exclusion, when all the scary things have been ruled out. It's the most benign cause, and the treatment is gratifyingly simple. Laxatives, enemas, and sometimes manual evacuation in cases of severe impaction. And this is followed by long-term management of the patient's chronic constipation to prevent it from happening again.
The easiest fix, but one that has to be differentiated from cancer first.
Always.
We have journeyed through the anatomical maze and the complex, often contradictory protocols of the right iliac fossa. We've seen that the exact same location can house an inflammation that requires weeks of waiting or a malignancy that needs aggressive removal.
To synthesize all this, let's review the 6 critical pairings of diagnosis and definitive primary management. This really encapsulates the core decision matrix for any clinician.
Let's do it.
First, the appendicular mass or phlegmon. Conservative management via Ochsner Sherren, followed by an interval appendicectomy 6-8 weeks later. Second, the appendicular abscess. Percutaneous drainage plus antibiotics, pus must be drained.
Got it.
Third, carcinoma caecum. Right hemiclectomy after meticulous staging and correction of anemia. Fourth, ileocecal TB. Long-term anti-tubercular therapy, ATT, with surgery reserved only for major complications like obstruction.
2 completely different paths for things that look similar.
Exactly. Fifth, Crohn's disease. Primary medical management with steroids and biologics, using a bowel-saving surgical approach only for failure or complications. And sixth, Psoas Abscess. Antibiotics plus CT-guided drainage.
That summary makes the divergence in clinical pathways crystal clear.
Yeah.
It emphasizes that in the RIF, the job isn't just finding a lump, it's accurately identifying its parent tissue, because that parent tissue determines whether you wait 6 weeks or you operate tomorrow.
That is precisely the challenge. The history and the imaging aren't just details. They are the certainty required to commit to these high-stakes divergent interventions.
Okay, let's end with the final critical distinctions, the takeaways we want the listener to never, ever forget about this particular clinical dilemma.
Right. We have to reinforce the 3 non-negotiables that govern acute care in this region.
Right.
1, never operate early on an appendicular mass, phlegmon. The risk of intestinal damage outweighs the benefit. Conservative treatment is the established, safer initial route.
Okay, number 1.
2, the CT abdomen with contrast is the investigation of choice in adults. While ultrasound is a cheap starting point, the CT is the tool that gives the comprehensive, definitive assessment needed to rule out or stage malignancy and visualize deep structures like the psoas.
And the final, most important one.
And 3, this is the clinical gravity point. Carcinoma caecum must be aggressively ruled out in the elderly patient presenting with an RIF mass. Age significantly shifts the probability towards malignancy. A clinician must never assume an older patient's mass is just an appendicular phlegmon that will resolve conservatively without actively and rigorously excluding cancer first.
It truly emphasizes that clinical medicine is often less about knowing all the answers and more about knowing the structure of the investigation and the required points of vigilance.
No.
We started with a definition of a simple swelling in the right lower abdomen, and we discovered a landscape of life and death decisions dictated by the proximity of 5 entirely different organ systems.
And what's truly fascinating here is the sheer burden of responsibility placed on that initial monitoring team under the Ochsner-Sherren regimen. They are actively choosing to wait and watch an infection cool down, knowing full well they could be missing a life-threatening, actively progressing cancer that looks identical.
It's a huge weight.
It is. And it raises an important question for you, the listener. If a conservative treatment path is chosen and the patient starts to decline, the CRP slowly rising, the pain slightly increasing, at what precise moment do those subtle signs of treatment failure outweigh the significant risk of an operation, forcing the surgeon to abandon the plan and commit to an emergency intervention? The margin for error is razor thin, and that daily check of the TLC and CRP is the only safeguard against catastrophe.
That's our deep dives into the RIF Mass and the intense clinical decision-making it demands. We hope this gave you a detailed look at the structure and stress of differential diagnosis. Until next time.